Medicine, and today we're talking about Oh my gosh. Hi guys, thank you for joining. This is Essence of Medicine, and today we're talking about informed consent. I'm Amanda Armagost.
And I'm Dr. Abbasi for Essence. So, informed consent. Have you ever had a surgery?
I've had my tonsils taken out, and when I did that, also my adenoids were taken out.
How old were you?
I think I was 17.
17. So, that's considered still legally minor.
Minor, but
But,
last year
but
or 2 years ago, I had a colonoscopy.
yeah, but we doctors, we still treat you usually like an adult, even legally, except for very, very limited things. You are still going to have the permission of your parent, even if you're 17.
Mhm.
For certain things, I think there are in some states, you're considered adult, especially if there are some reproductive things and so on. But otherwise, he treat you like an adult. So, did you have the feeling that you were treated like an adult when you were 17 with the? Or,
Probably, honestly, I that was like 1 decade ago now.
wow.
Yeah, so I don't remember it, to be honest. That's why I
Yeah.
brought up my colonoscopy I had in 2024.
Okay. So, can you go over the your conversation with the doctor about the consent part of the conversation?
Yeah, he just explained to me, well, it wasn't him, I think it was the NP. He explained to me what was going to happen and what steps I needed to take ahead of time, and maybe what the risks were, and then what steps I had to take for my recovery.
Hmm. Did you have a conversation with the actual doctor who performed that?
I don't remember having a conversation with him, but I'm sure I did.
So the colonoscopy is probably a smaller procedure, but in for any major procedure, actually the doctor converse with you about the risk versus benefit. Did you sign? Did you have to sign a
Yeah, had to
consent?
sign. Mhm.
Now, lots of people, the mistake that that paper that they sign as a consent, that paper is a literally documentation of the consent. The actual consent is the conversation that you have with your doctor to good extent to explain what that procedure is, why that procedure is being recommended, and that you understand especially the risks versus benefit of that procedure, especially the risks, and then what alternatives are to that procedure, and then you give the doctor permission, because without your permission, doing that procedure, believe it or not, is legally like an assault.
Sure, of
No
course,
different
yeah.
than putting a knife in you in any other way, because that's exactly most of the time we do. We put a knife in you, and but when we explain to you why we are doing it, and obviously we understand that a lay person may not understand everything like a doctor would understand the procedure, but that's then on us to try to make it as understandable as possible, especially that the overall goals of that, and as well be realistic about the risk. Now, obviously, there are certain risks of any procedure, and no procedure ever come free of risk. And we go through a certain like a legal requirement that you may die of that procedure. And realistically, these days those risks are very low, obviously never zero. And obviously, every time we do a procedure, the surrounding tissue, we have a goal to do something to one part of your body, but that part of the body is not literally in vacuum. The rest of you is around it.
Mm-hmm.
And so we have to get there. And we have to, for a good amount, to explain to you that what that surrounding structures are, what are the risk of that, um, and they make you understand what the risk associated, general risk and specific risk associated with that procedures are. Now, unfortunately, 9 out of 10 patients, they just dismiss it, and even though we go through that process, they think that's not going to happen to me. But
Yeah, of course.
and that's understandable. But everything in medicine is statistic.
Well, and I think also from a patient standpoint, sometimes it does feel like an overload of information when the doctor's talking to you. In my experience,
Hmm.
sometimes I've actually felt like the doctor wasn't really talking to me, but talking at me they have a spiel memorized and they're
Hmm.
just rambling on about their spiel kind of in almost idle mode. You know what I mean? Just kind of going through the steps. So I can see why
I know
as
what you're talking because I'm on the other side
yeah,
of it.
exactly. So as a patient, that can feel kind of overwhelming sometimes when you already don't understand the medical jargon.
No, well, with the medical jargon, we can lay it down, speak it in a lay language. We don't need to say like, the duodenum. We can say the upper part of your intestine, and we don't have to. We can lay it down to a certain point, but obviously, it's going to be an illusion that the patient would understand it as much as a
Of
doctor. That's
course.
just not going to
Yeah.
be possible. Um, but I think sometimes what I think is important, that create a relationship to the patient, and I think for me that relationship is more important. And I mean, we doctors, we create our own routine. My routine is that I first of all I always look at the pictures on the. I mean, my job is a lot of the involvement of the picture, MRI, CAT scan, and so on. And um, I think I have a good way figured out, a good way to make the patient understand with analogies, like instead of saying this is the herniated disc pushing here on the nerve and so on in the lateral recess, I say a disc is like a tire of a car. Imagine you have a flat tire and the bulging part of the tire is what here pushing on that nerve. That's why you have the pain going in the back of the thigh.
Hmm.
And that's why I ask you why you don't have a pain. If you have pain in front of the thigh, because that nerve would be right up here, and having a model and pictures, it's extremely helpful.
Yeah, I think having a model is huge because actually I was just at the doctor yesterday and I was wishing that they had a model because they were asking me about my pain and it's like I can't really show you where my pain is inside my body because I don't have a model to use and I can't explain it.
Can you now let me ask you? Can you
Mm,
push, put your finger on where your pain is right
no.
now? No,
No.
no. Is the pain? It's not in your head. It's not in your shoulder. But you can generally, point to the
No,
area.
it's internal pain. I
But
mean, but I don't want
yeah,
to do it right now.
no, no. But in your body, you can put the hand here. Is there pain, or is it lower? Is it
Do you
right? Is
really
it
want me to
left?
explain it? Because it was GI stuff. So I can explain to you what I was saying.
Well, I think I want to demonstrate to you that there are ways to communicate with the
Yeah.
patient. Yes, just show me where the pain is. Just do your best.
Okay. Well, the pain is like right here,
In the
but internally,
yeah,
but
internally in the buttock on the right side.
no, inside the
Yeah,
rectum,
yeah,
midway through.
midway through. Okay, you
Yeah.
explained it. So
But I
that's.
felt like he didn't really understand what I was talking about
Mhm.
because then he kept saying like other stuff. Like, no, I'm not talking about exit pain. I'm not saying like
Mhm.
the whole itself hurts, but you know what I mean? Like,
I'm a doctor. You can say
yeah,
that
but these
they.
people aren't. These people watching aren't doctors.
So let me now try to explain to you. First of all, the idea is that the patient feel comfortable
Yeah.
talking about
Oh, and
uncomfortable
I
things.
totally feel comfortable with my
Good,
doctor.
good, good,
Yeah.
good. So, and then creating a relationship that you feel comfortable, that you can talk about things, and then as well, telling to the patient, okay, I'm going to go through a series of side effects. Like I tell every single patient of mine, you may die of this procedure. That chance is low, but it's not zero.
Yeah.
And you see, but I don't. You cannot just stay there and that there's a chance that you will die of it, and then just move over. We have to just put it in perspective. But yeah, tell everybody, you may have a stroke, you may have a blood clot, you may have this and that. These are all realistic risk of the surgery, but in realistically, those risks are low. And I tell them, like nobody ever had that side effect or complication in my hand. Or I had a handful of patients who had that, like certain thing, like there's a procedure we go from the front and we take care of the disc from the front of the neck. We call that ACDF. There is like a 25 to 30% in literature risk of problem having problem with swallowing. Vast majority of that after a few weeks get better. And I tell the patient that, yeah, these are the risks associated with that. It can be very mild, it can be very severe, and so on. It's a realistic risk or like risk of infection.
Hmm.
Like um, everybody as well, obviously think they are not going to get infected
Yeah, no one thinks anything bad would happen. Most people don't think bad
because
things would
they
happen.
think medicine is 100%. And that is the wrong way to see the medicine, believing that we have supernatural abilities that we don't. Okay, now I put it as well in perspective. Like I say, the risk of infection with a regular surgery is 3 to 5%. With my surgery is 0.4%. And that is where the data comes in. We have to keep track of our own thing, not to do the gut feeling. Like I know a lot of surgeons, they say, oh, that's a rare thing. But when you look at them, it's not rare in your hand. Or, you have to be just honest and realistic to the patient. Tell them, like, what is that risk in your hand, and then keep track of what is your hand. That's the best way to be honest to the patient, and that as well gain a lot their trust, that you say, that's one of the things I tell all my patients. Ask a surgeon, how many of this surgery have you done?
Hmm. But is it also the surgeon's obligation to keep track of other surgeons' results? Meaning,
No,
like,
no, that's not our obligation to keep, but it's obligation for us to know what is the general risk of a procedure,
mhm.
and then what is that risk of that specific risk for that procedure in my hand.
Because obviously technology is constantly changing. So
Yeah,
how often do you have to look into the general risk of the procedure?
if you're a specialist, you have to do it often. If that's what you do. I
Hmm.
mean, like if you are a farmer in Alaska, you may not need to know the rules of the street rules in New York City. But if you're a taxi driver in New York City, you need to know what are the rules of being a taxi driver in New York City. You see, I used an analogy that makes sense, and that's a lot of things that you can turn them in analogies that make sense for individual patient. Now, let's come back to that. I don't need to know what the risk profile of this surgery in my other colleagues in the other hospital here in town, but I need to know what is the general risk of this procedure, and more importantly, what's the those risks in my hand. Now, and there are certain things that I felt uncomfortable when I started this procedure, that this profession. Like they would ask me, how many of these procedures have you done? Well, I have done 3 of that when I was a resident.
Yeah.
You're my first patient, and so on.
Well, every procedure needs a first patient.
Yeah, yeah. I mean, obviously you do that first with the supervision of somebody else and so on. But I think I had the literally the I would say uh, benefit, but other people say, "Oh my God, how did you do that?" I didn't go through one residency. I went through almost 2 residencies, and I had the general residency takes about 7 years. My residency was twice that much because I did it started in Germany and came over and so on. So I had lots of experience, but still there were procedures I haven't done, and that obviously that put you in a situation that you have to be honest to your patient and just tell them like, let me tell you, I have done thousands of spine surgeries, but when I did the Olaf, my very first patient, and this is what my conversation with the patient was, I have done a lot of this surgery. I'm very familiar with anatomy. I have seen this procedure that now, and I have trained on that and cadaver, that it reduces dramatically the damage to your tissue. But guess what? You are my first patient. I'm going to do that, and but if there's anything, I can just do it old-fashioned way. So I feel very comfortable doing that. That as well, you have to be honest to the patient, and that patient still talks to me. I did the surgery, and that patient, and I was very happy, and the husband and the patient, they later talked to me, said, you were glowing, that it was, you were amazed how good this procedure, I'm talking about Olaf. And I saw that patient 7 years later for a different spine problem. And that was what the reason she came back to me,
Mhm.
because she felt that I was totally honest about, what it is, why I'm doing it this way. And they still remember how happy I was, how good the surgery went, and so on and so forth. So um, um, I think once you create that relationship to your patient, that they trust you, they're very forgiving. That you haven't done like tons of those procedures. Now the problem becomes, if a patient has a totally unrealistic expectation, like the same thing that we all, nobody they expect a complication to happen, but guess what? They happen. They happen even in best hand, with somebody that has lots of experience and so on.
It's just statistics.
The human body is just the medicine is statistic in any regard you can imagine. And if that number was zero, obviously then it wouldn't be a complication. We would have zero complication, and everything would be 100%, which is just not the way it is. um, Often I see that patient, they are there, they understand that, but then the family, when if, especially if they have not been in the process, involved in the process, that's then all of a sudden they have this unrealistic expectation that nothing ever should go wrong and
Mhm.
medicine is 100%. So I totally appreciate if patient they come to me with their family, and unfortunately that happens in 1/3 of the case. But then as well, I totally appreciate if they have done their homework, if they have gone and read about it. Especially, I love it if they have talked to other surgeon, and and if they not, if they haven't, I that's part of my consent. That why I established in our consent form that I have to, our doctors have to encourage the patient to get a second opinion. Obviously, the patient has autonomy; we cannot force anybody, but our job is not done, and we don't schedule a surgery unless we have strongly recommended to the patient to get a second opinion, and you should do that. And I've noticed that exactly because I feel so comfortable with that, um, and the patient actually gain more trust, because that's what I tell to the patient. If they're surprised when I say, go please, you won't hurt my feeling, get a second opinion. Even if you get the information from me, go to another doctor, and then choose them to take care of you. This is not a car dealership that I get upset because you got the information from me and bought the car from a. But
But how common do you think that is? That other doctors say like, "This is what I can do for you, but I really suggest that you get a second opinion."
how I think, I mean, no, I don't have a statistic, but I think that should be a routine.
I think it should be.
Yeah, that and as a matter of fact, what I tell to the patient, if you go to a doctor, no, I have seen the other way that they literally stand up and walk away. I have seen that as well. When as soon as you mention, I'm going to get a second opinion, um, that's beyond unprofessional. But what I have seen is that some patients are so surprised when I tell them, "Hey, you won't hurt my feeling. Get a second opinion." I encourage you. Just the fact that many patients are surprised about that, that tells me that it's not a routine thing, but it should be a routine thing. And one of the things I tell to my patient, if you mention a second opinion and your doctor is offended or upset about that, it's a lot more reason now to get it. You absolutely should get a second
That
opinion.
would make me lose all of my confidence in my doctor. Like, what are you so scared about?
Yeah. Um, um, I can speak that, we doctors um, are sometimes we feel we are in a position of authority, and unfortunately, some may see that somebody is questioning our of authority or competency and so on and so forth. Whereas a more experienced doctor would see that as a way to connect to the patient.
Mm-hmm.
I am on your side.
Get their
I'm not.
trust.
I'm not. I'm not talking down to you, talking at you. I'm in the same boat with you. I'm here to help you, and I think that sort of truly gains their trust. Now, again, it problem comes is that we do all of that, and then the husband, a wife, a daughter, somebody who never was there, and then if something happens, they come and you see that they're more upset than the patient themselves. The patient said, "But yeah, but he told me that." That may happen. I've seen that a lot, and that is the value of creating that trust. That
Yeah.
sometimes as a matter of fact, when something like that is in the case, that something is not a perfect outcome, my patients sometimes defend me from their significant other or family member,
Because the family member wasn't there probably during the consent
especially
process.
if they weren't there. That's
Yeah.
why I know in some cases I tell to the patient, listen, this is, we know we talked about that, but come back with your wife. Go talk to your wife. It's always a family decision and so on, because they have to take care of you.
Yeah, that's
Come
their part.
back, come back with this. Does not need, don't be in rush. Sometimes, like if patients have an unstable spine and is losing function, I say, hey, I describe the situation. I say, go talk to your family, but make a decision in the next few days or few weeks. I have a good understanding, what is the time frame, but 90% of the time I say, don't be in rush. This is one of the phrases I use, and that put them at ease. Do not feel you have to make a decision today. That's sort of very helpful. Now, if you're a doctor and you just haven't had that much, experience with this processes psychology, now obviously we have to have the technical expertise, but a lot of what we do is as well the psychological aspect of how to put the patient at ease. And for them, we are going to cut you open. We are going to be millimeter away from your spinal cord or brain or whatever, and how to make it easy, understandable, and put the mind at ease. That's a thing we do not learn in the residency. Okay, so, but this is one of the phrases I recommend you if you're a doctor, use a lot. Okay, if it's not a
Like your dad.
emergency case, tell them, don't feel you have to make that decision today. Go think about it, talk to your family, get a second opinion. I strongly recommend that. And that often I tell my patient, hey, if it was my body, I would get a second opinion. And that sort of take the entire stress off them, because they don't want to, they don't want to disappoint you and so on sometimes. Okay, but that takes the stress completely out of them to actually go get a second opinion. Um, my experience is that 95% of them or more, they come back to me.
Sure. Isn't it true that sometimes doctors kind of get financial benefits from device companies for using certain implants or
in
tools?
various way as well, they do, and
Is
we have to disclose that.
Yeah, I was going to say, is that part of conform or informed consent?
Absolutely, it is.
What is to explain to me what that looks like if I'm a patient and let's say I'm not going to say a specific device company, but let's say you're getting money
Oh,
back.
let's say like Securely Action, I created the device. I'm proud of it. Not only I disclose it to the patient, I tell them why I built it that way. Like, in the sacroiliac joint, we have to put screws in this between the sacrum and spine, a sacrum which is part of spine and pelvis. I say, yeah, this is the procedure. It was a time we did it a different way, but now we go this way from outside to inside. But look at that. I cannot put one screw in because it changed, it still rotate. We have to put more than one screw. I have developed the method. I have to poke you only once to put three screws, because the second and the third screw go through the screwdriver of the first screw. Every time I poke you, I put your tissue at the danger. By poking you only once instead of three times, I can not only be very efficient, but literally reduce the dangers associated with every time poking you. No, you're not going to have that surgery, but did you understand what I just told you?
Yeah.
So you see that's an easy way. So in my case, actually, I develop new methods and so on, and certainly um, that is totally changes the risk profile for the patient, reduces it tremendously. not only I disclose that, I'm proud of it, and they love it when I um, explain it in terms of.
But I think that's different than the question I'm
Yeah,
asking
what's the question?
because you worked on that directly. So obviously, as a
Mm-hmm,
patient,
mm-mm,
that's going to make me feel more comfortable because
mm-hmm.
you were involved in the process and everything. But let's say Medtronic,
Yeah,
that's a ginormous company. You had nothing to do with this screw, whatever that you're going to be using.
and
Do
then
you have to tell the patient, by the way, I have a contract with Medtronic. I benefit financially from, like, you know what I mean?
intuitively, I think you should say that, and there is a web page. You anybody can go and check on that.
Open
But I
payments.
open payments, but I know they don't. I know they don't.
So it's not part of the consent process that they have to, because as a patient personally, I think I would like to know if they're using something because it has a financial benefit versus because it's what they think is the best.
I want to believe in the integrity of most of my colleagues to believe that if they are getting paid from Medtronics or anybody else, they are doing consulting for them, helping to develop something, go educate other people, and so on. But I'm not naive. I know in some cases they just do a lip service to bring the business to the hospital and so on. So I'm not naive to, but overall, I want to believe in the integrity of my colleagues that at the end of the day, we are there and we truly commit to patient care.
But is it an obligation? Like, do they have to say it?
I don't know, but I would intuitively believe yes.
Okay.
I don't know the answer to that. It's a legal question, but I sort of, it's part of our paperwork. When anybody who comes to us um, has to see a list of paper that, yes, we developed this, we are involved in this, we earn money on this. But on the other side, every time I do surgery, I earn money. So, um, but I still tell to the patient, hey, this is my surgery center. I have financial interest.
Mhm.
Well, I have okay, disclosure. I have a financial interest to be a doctor. I get paid
I mean,
to be a doctor.
who doesn't? Yeah,
So,
but
but
it's
we go
just,
beyond that. We go way
yeah.
beyond that. We tell them that, okay, this is our surgery center. Yes, we have financial interest in that. This is the devices that I have produced. I go around the world, by the way. On the other side, um, many of these patients, they go and see that I have been in other countries and I teach other people and so on. Many of them, they have done their research, their job. They know that we have donated our intellectual property to developing country. Overall, it comes back that you become a partner with the patient,
Hmm.
not and you don't see the patient as another source of income. This is not a car dealership. That's all I can tell about that. And gaining the trust is the most important part.
So when new procedures come about or come up and become popular, obviously there's data that backs it. If it is higher risk or lower risk than the original
Mhm.
procedure, that it's doing the same or solving the same
Mhm.
problem. And it's kind of up to the, in a way, up to the individual doctor whether they believe or don't believe this data that's coming out.
Mhm.
For example, we have these LinkedIn warriors that we've talked about quite a few times where you'll post data and they just want to argue with the data.
Yeah, yeah. Obviously, medicine is not as unified as people believe it is. And that's in part maybe a good thing. We need to have different expertise, different people doing different things. People are good at different things to be able to just try always new things and so on. I can tell you a personal story that when I was started, my after residency, my practice, I had a lots of experience, and I was good at what I was doing, traditional spine surgery. And when somebody told me in 2012 that he knows of a new procedure that performed this procedure with this profile, I physically, literally, my reaction was bullshit. That's not possible. But I think my blessing was I didn't say bullshit and I walked away. I said bullshit. I want to see it. And then I went and I saw it, and I saw that patient leaving a surgical center a few hours after the surgery. I saw the procedure, and and then I started learning about it. Okay, I didn't say bullshit and just walked away. I think that's a problem. Many of our colleagues, if it is not what they do themselves, they say bullshit and walk away. And no kidding, I went in 2014 at that time to the chair of the neurosurgery in University of Minnesota. Um, that person obviously is retired now. And I said, look at my data. And he said he doesn't have time. I think if you don't have time to look at the data, you shouldn't be in that position.
But can you really, because isn't part of conform or informed consent telling patients their options?
Absolutely, absolutely. I think part of our see, we say informed consent. You have to talk to the patient about the alternatives, right? First of all, you have to know alternatives. And let's say that there is three ways of doing this surgery, and you are familiar with one of them. And you obviously need to tell the patient, yes, the surgery is as well possible in other ways, but I do it this way for this reason, or sometimes I do it this way because I have the most experience in this.
Mm-hmm.
And you can talk to patients. There are people, they understand that. You know, if you are used to driving this car, that the car you are most comfortable and most safe to drive. Um, let's be very clear, okay? Is if there is another car that has a better safety profile, but you have never driven it, you're still safer with this car. So people understand that and are very now they accommodating if you are just come clean about that. But the problem is that if you go to tell to the patient that this is the only way of doing this, um, just because I'm doing it this way, and that happens as well. And lots of those LinkedIn warriors are like that.
Mm-hmm.
They only know one way of doing that. The interesting part is that after now, obviously, there is a traditional way of doing spine surgery, and there is a minimal invasive of doing the surgery, and I'm obviously advocating it for 14 years. For the first 7 years, everything was wrong about that. After that, for some of these LinkedIn warriors, they start doing the variation of that, and then they put, after putting the 30 cases, they put the result out there. Oh, look at how beautiful I think it is. My reaction to that was, finally. I have no interest to go there and you remember all those things that you were saying that
Yeah.
why nobody should be doing that, and now you're saying the thing. My thing was it is actually that was my reaction to that was, finally, it's a good thing that we are going that direction because it's good for our patient now. But nevertheless, you're coming back to your question. Yes, you should be aware of other procedures and explain to the patient why you don't do that, and that's okay.
But what if you're seeing the data, you're seeing the evidence, and you are just rejecting like you're
Oh, you
rejecting
can
the
say
data?
you can say to your patient, we're talking about consent.
Mhm.
Academically, I think that's lazy. Academically, I think it's just that I would say, would I use the word dishonest? But I
I
would
would
use the
maybe
word.
say manipulative.
No, I would say, I think academically you are not doing your due diligence. Okay, you have to compare the thing, and sometimes is that the results are not really clear, or you can find a paper for anything. You don't have to believe something just because somebody else says so or there's a paper about it, but you have to talk to the patient. So, like, um, uh, the risk of infection in our surgeries, you have not seen me doing a take back of the patient to the surgery for infection after OLAF because I haven't. I mean, okay. Um, uh, but there is a risk of infection with our procedure, with the other procedure. But let's say you do only the open traditional procedure, and you don't believe the result of that. You can as well say, yeah, I mean, there's risk of infection here and there. Those surgeries they're claiming to have lower risk of infection, but I think the other risks are maybe are there, and for that reason, I think weighing risk versus benefit, and you feel free to say that weighing risk versus benefit in my hand, I still recommend the old-fashioned procedure. But I think not talking about it at all, I think you have not done your due diligence on the informed consent. Patient need to know, especially high risk patient, which by the way, they're being rejected. They're not like being consented knowing they have high risk. They just say, um, you're not qualifying. And if by some very cynic the doctors, they're just being, actually not only rejected, but saying you don't need a surgery.
One thing I've seen though, which I think is almost worse than what you just said,
Hmm.
is when they reject the patient. They say you're rejected for this reason. Your BMI is too high. But not only do they not say there are other procedures that you could that may be safe for high BMI patients. I personally haven't done it, but then they kind of
Body shaming.
badmouth you.
Oh
No,
yeah,
I've seen that as well, body shaming, yes. But I've seen when doctors turn away a patient, say their BMI is too high, the surgery is risky, but then in the same sentence badmouth
somebody who can do
someone who
this,
can do it.
who can help the
So
patient.
it's like a double rejection.
Well, I think this is another thing. If you're a patient, if you go, do you remember what I told you? If a doctor get offended, if you get a second opinion, absolutely get a second opinion. That is a red flag for a doctor. If any doctor, very point blank, talk bad about any other surgeon, that is the reddest flag you can get. You will never hear me saying that doctor uh, is a bad doctor, or what he's
A
doing
hack.
is wrong, or and so on and so forth. This is the reddest flag you can get from any doctor. As a matter of fact, I think that the reddest flag you can get from any professional, period. Or like, oh, that electrician is he's a hack, and so on and so forth. If the best thing I have to tell my patient is telling how bad others are, if that the best thing you can tell, uh, that tells more about you than them. Now, I have told to the some of the patient, okay, I know Dr. X, he's a good doctor, he has the best intention, but for this reason, I don't recommend this at this point. I've said that to
That's
patient,
okay.
but telling that, oh, that doctor is a hack because he said that, oh, that doctor is this and that and so on. That tells more about those doctors than about me or anybody else. And so this is another red flag, and I think that the reddest flag you can get is the best way they can tell you how competent they are is to talk bad about others. Don't walk, run away.
Definitely. What else do you think patients need to know about informed consent? Something that they might not.
Um, and one of my best thing is that I put a lots of information out there. And when the patient come and they already have done their homework, they have researched, and they ask questions, okay? And that's one of the things I take really my time. And by the way, sometimes, and it's less now with AI doing my documentation, but it used to be that some patient had to wait 2 hours to see me, and they were fuming. But when they left, they were happy because they knew the reason they are late because I took my time with
Mhm.
the patient, and meaning that taking the time explaining things. And now obviously sometimes as well somebody asks the same question 5 times, and they just want to hear a different answer because they don't like the answer I'm giving to them. um, and then I confront the patient. I say, I know you're asking the same question, but let me just be clear. I'm going to answer this question the same way you asked it the last 4 times, because that is, in my opinion, the right answer. And and so, uh, but what I'm getting at is that coming honest and be communicating honestly with the patient. 95%, 98% of the patient really appreciate that. understanding what how you're thinking, why you're thinking that way, what your limitations are, and why um, the, this procedure may or may not help them in what regards. Even tell them, you see, I think this will help you with these symptoms, but you're not going to get your shoulder fixed by me doing surgery on your lower back. I'm exaggerating a little, but there is a lot more nuanced kind of information we can give to our patient. And as well, the good news is here that um, if you make the patient understand and if they have done their homework, they the communication channels are much more easy for the doctor.
Okay. Thank you guys for watching. We talked about informed consent. I'm Amanda Armagost.
And I'm Dr. Abbasi for Essence.
Have a good night.